Welcome, everybody. My name is Doreen Zetterlund. I'm a CLL, SLL patient and patient advocate, and also a member of the CLL Patient Advisory Board and your moderator today. We're live with CLL Society's second Facebook Live event, Ask Me Anything, where we spend the entire event answering your questions with a renowned CLL specialist. We're so lucky to have Dr. Nicole Lamanna with us today. Now, there are no presentations, and we encourage you to ask questions on the Facebook page if that's how you're joining us, or through the Zoom platform. The event is dedicated to your questions, so ask them early so we can try to get to them all. Before we begin, I have a few important disclaimers to share. Nothing said today should be taken as medical advice. Your questions about your health and treatment should be discussed with your healthcare provider. The information you post on Facebook will be shared in a public forum, so please do not post confidential information. And without further ado, Dr. Lamanna, would you please introduce yourself for our audience?
Hi, thank you. Happy to join you all. My name is Nicole Lamanna. I am a leukemia specialist at Columbia University Medical Center, just a humble CLL doc, hoping to help whoever I can.
Great. All right. Well, let's get going with the questions so we can get in as many as we can. We've tried to group some that we got in advance in some kind of order. So we'll start with some COVID-related questions. And the first question is wondering what your thoughts are regarding people with CLL on or off treatment who rapid COVID test positive for weeks or months after their initial infection.
Yeah, I mean, so the COVID issue I know is a very popular discussion and topic amongst our CLL patients in general. There is no doubt that you all, many, I should say, can have a test that's positive for quite a while. This is not just unique to COVID, just so you know. Back in the day, also the flu and RSV, there are some patients who are very immunosuppressed, and sometimes their swabs can be positive for those viruses as well for a very long period of time. I think the difficulty we have with COVID, of course, which is different, is that the quarantining issue, or how long somebody should remain in isolation based on the positivity or negativity of the test, is what is in debate. Because we know that the antigen test, it could be due to the fact that somebody is still shedding virus, or it could be that there's just viral debris that the test is picking up. And so what the experts debate about is it that somebody should really still stay in quarantine because they're still shedding virus, of course, or they're asymptomatic and maybe it's just lingering viral debris. And that's what we don't know. So I think for the most part, this is something that we still need a lot more information on. I usually tell my patients that for sure, obviously, if you're symptomatic and you're really coughing and still not well, then I'd probably quarantine longer. If you're otherwise asymptomatic, but for sure, for protection of other people, if you're going back out and you're still testing positive, if you're asymptomatic, I would certainly still wear a mask. I mean, I would still wear a mask in general. For you all, I think that's what I recommend to all my patients, is that you guys should still be wearing masks. But for sure, if you're not sure how to extend or not extend the quarantining part because you're still testing positive, talk with your physician, of course. But if you're asymptomatic, you're probably okay, but I would wear a mask just in case, because we don't know if you're shedding virus, okay?
Okay, to protect others.
I can answer that.
Yes. Okay. All right. Continuing with some COVID questions, can you provide an update on how CLL patients are doing with COVID-19, especially with the new variants?
Yeah, and obviously, guys, just so, obviously we know that this is in flux. So you have to understand that the information is rapidly changing and evolving, as are the variants. There is no doubt, though, compared to 2020, that the community at large and the CLL patients as well, in particular, are doing much better than we, had experienced a couple of years back when we had lots of morbidity and mortality. It doesn't mean you can't get sick, but the point is that I'm seeing a lot less, thankfully, a lot less hospitalization rates due to COVID. So it doesn't mean you can't be miserable and sick with the virus itself, but most people are now staying home and remaining home, which is great. Very few I can actually name on my one hand, and it's now December, which is wonderful to think 12 months ago, how many patients of mine have actually been admitted to the hospital. is less than a hand. And that's very different than what 2020 was about. I want to remind people, and maybe this will be helpful, is what I'm actually seeing now, which is a little different than 2020 and 2021, was similar to what I used to see with the flu and RSV. So patients will get through COVID or whatever viral infection, but the virus can make you run down. And sometimes that can predispose you to get a superbacterial infection. And so oftentimes what I'm worried about now is actually not the first week or two of COVID, but what about week 3 and week 4? After COVID, are you still recovering okay? Remember, it's okay to have some lingering symptoms maybe for a little while, but are they at least generally getting better, right? So even if you got a little cough, but it's still persistent, but you're getting better overall. If you're not, again, I would call your provider. What I get worried about are the people who are still lingering, not getting better, beyond week 2, really having a hard time, productive cough, fevers, those things. And do they have another infection on top of that warrants to be evaluated? And so that's actually the hospitalizations that I'm getting is very similar to what I used to deal with the flu or RSV. Every year I'd get a couple people admitted due to a superbacterial infection. They'd get pneumonia or sinusitis and come in the hospital that way, needing IV antibiotics after their viral infection. So a post-viral complication. So keep a lookout for that. Make sure you're getting better. If there's any problems, please call your physician and team, because that's what we want to make sure you guys all get through that.
Okay. Because things are changing with the variants, is there anything else now being worked on to assist CLL patients against COVID? Because some of the things we had are...
Sure. So, obviously, right, we talk about, obviously, the vaccines in general. That's one, way to try to help prevent severity. Remember, just because you get a vaccine doesn't mean you can't get COVID, folks, just like the flu and RSV or any other virus, right? It's hoping to prevent real severity of illness. And obviously with the monoclonal antibody treatments, the goal was to give people antibodies, particularly if they didn't, if they lacked robust antibodies for different reasons based on your immune system, or maybe even the therapies you might be getting for your CLL or both. The point is, those types of antibodies were to be helpful as well. Unfortunately, as many of you have probably heard, many of the antibody treatments, such as Evusheld, which are some of the more recent ones, Regeneron was a couple of years ago, and there are others, that many of them don't necessarily work against the newer variants. And in fact, they've been pulled, right? So the question is, will there be newer monoclonal antibody treatments coming around? We hope. We don't know, because it depends on how quickly the variants change. Many of you might have also either received or been aware, we have the antiviral treatments, both oral and intravenous. So drugs like Paxlovid, which are 2 antiretrovirals, and then something like remdesivir, which is an intravenous medicine. So those are direct antivirals that are trying to stop the virus from replicating in a different way and so those are available as well. So those currently are what is still available. Drugs like Evusheld have been pulled, and we'll have to see if we're going to have newer monoclonals in the future. But certainly these antiretroviral treatments are what's currently available now.
Sure. Well, with the holidays coming up, we have a few questions still about COVID. I have indolent CLL and would like to gather with friends and family over the holidays. Would negative home antigen tests done prior at the door of the gathering give sufficient relative safety for, say, a 3-hour meal?
These are always tricky questions, right? And there's always no guarantee of any of this. Let's put it this way, guys. I think that it's important that we are in a different phase. Do I think that things are certainly better? I do. Do I understand, though, that some of you might be more immunosuppressed than others? Of course. And that you definitely, I think, also should talk about that with your treating physician too. But there's no doubt that, many people lived in a very secluded and quarantined, even if they didn't have COVID, self-quarantines position just because of what was going on the past 2 years, and understandably so. Things are getting better, and I'm very hopeful by the fact of what I see, with this past year in terms of the lack of severe illnesses and things like that. So I'm very hopeful, but it is a personal decision too. There's no doubt there's a little bit of, you have to sort of weigh the risks and benefits of getting together with family and friends as best you can. At the same time, we all want you all to enjoy your life too. because, depending upon where you are in your CLL journey, I mean, COVID's not going to go away. And the question is, what do you feel acceptable doing in terms of your family and friends? So I think that's one you have to self-check yourself as one. When it comes to the testing for events, of course, having an extra layer of having some testing done is always helpful. The problem with, just so you know, the problem with testing, of course, is that sometimes the home tests are not always accurate either. And in fact, there are many of my patients where their home test was negative and I was convinced they had COVID. I said, you really got to go get a true PCR test, and then it was positive. So there are some limitations of the testing that we have, and you have to keep that in mind, right? So I think that, certainly I would say that you don't want anybody who's sick coming to a friend or a family event if they know they're actively sick. That would be an easy thing to be no. There are other ways. I know that, some of my patients have said, well, I'm getting together, I'm going to wear my mask, I'm going to eat in another room, or they're having partly an indoor outdoor, although it's getting colder in some states. So I understand how the limitations of that, but some sort of way to maneuver that, or having smaller gatherings. There's always a risk. You're going to, obviously, there's even people who are asymptomatic, could be a carrier, or develop COVID shortly after the event. And didn't know it because they picked it up earlier. So there's always those potentials. I think that, again, you sort of have to weigh the risks and benefits of your condition, where you are in your journey, along with, celebrating, a time with family and friends. And I think it is more normal for folks to get back out now, given how well things have gone. Not to say that, it's perfect, but the point is that people overall are doing much better. And so of course the desire is to get together. So I just think that, it's hard to answer that question specifically. It's not a one size fits all, and you have to feel comfortable as well. But I do, depending upon where you are in your journey, you might really do want to gather and see family and friends depending. And so I think it's important to do that, but you got to weigh that for yourself. It's a tricky question to answer, but not if this was 2020, I would say no, but it's not 2020.
Okay, no guarantees. We have to use our good judgment.
Exactly.
Should CLL patients be seeing an immunologist to address gaps in our immune system, not just with COVID, but I guess in everything? And we'll move on to other topics now.
Typically, no. I mean, don't get me wrong. I think this is a trickier question because I'm not sure immunologists are, I think your physician might have more, your oncologist and hematologist may deal with this type of issue more so necessarily than an immunologist. Not to say that they're not good, but the point is that the person who's seeing you hopefully sees lots of CLL patients. The tricky thing is there are some things that are knowable and from experience, and there are others that are less knowable. I think that there are gaps. Of course, there are absolutely knowledge gaps with as we learn more about CLL and this disease in terms of people's immune system. And it's definitely not one size fits all. I'll give you an example. Hypogammaglobulinemia, right? So about, many patients with CLL have low immunoglobulin levels, but that's a poor surrogate cheap marker for us looking at your immune system. There are many patients who have low levels and never get sick. So, us giving them immune globulin or replacement therapy is not something I would normally do for that individual because they're never getting sick, despite the fact that their IgG level is very low. And yet there are some patients who have normal levels and they get sick all the time. So the point is that this is not perfect either. And the point is that you really, we want people to be on alert. So if you have any signs or symptoms of infection, I'm the first person that I want my patients to call me, along with my nursing and my NP, and they know that, so that we can either, jump on that person if they need to have more evaluation or antibiotics or something, testing or what needs to be appropriate sooner, so that we can try to make sure that somebody doesn't get really sick from whatever they're going through. Those kind of errors. So I don't think you necessarily need an immunologist. I think you just need you need to work with your physician and team really closely. If that, to be fair, sometimes your oncologist may say, you know what, I'd rather you call your primary care person instead. So do whoever's the go-to that, when it comes to infections and issues thereof, whether it's your team or your primary care doc or so on and so forth, you want to have a good communication with them, so that you can let us know, so we can see if we can help you if you're getting sicker. Not to say you can't go to an immunologist, they can do some testing as well, but I'm not sure where that may help you. I think your team needs to be aware.
Sure. Well, your CLL specialist will direct you if you need it.
That's
Okay.
what I would do.
Okay. Okay. We're going to move, we've got lots of questions, so I'm going to move on to some other topics, and we'll circle back if we have time. Would you explain the difference between monoclonal B-cell lymphocytosis and CLL, and what differentiates the two?
Good question. Okay, so MBL is sort of, think of it a little bit like a precursor. So these are folks whose lymphocyte count is less than 5,000 in the blood. And so they have a very low level of disease. So they're technically not called CLL because, again, their lymphocyte count is less than 5,000 in the blood. Okay. And for some of these individuals, they can never, ever transform, or I should say evolve into more of a leukemic state where there's more than 5,000 lymphocytes in the blood. And so that for those individuals, again, similar to many CLLs who are on active observation and monitoring, you guys call it watch and wait. I changed my tune. But the many of those individuals are just monitored as well. Now, do we think that patients in the course of MBL or early in the course of their CLL, their immune system is probably more intact? Likely, yes. And so for some of those individuals, we don't necessarily lump them in exactly like CLL patients, although there are some MBLs who progress quite quickly into a more CLL-like phase. And your doc can talk to you more about that depending upon some of the markers and things about your MBL. There are some of those that do advance more quickly into CLL, so they can then be a little bit more different. But again, these are patients who are not quite CLL patients, and some of them may be monitored for many, many years before they become CLL or never develop fully into CLL.
Sure. Okay, what is the typical number of markers the average CLL patients are usually tested for?
Oh my gosh. I'm gonna think that what you mean, let me tell you what's important about testing, because there are these large panels, and maybe that's what you mean. There are large, or the person who's asking that question, there are some large lymphoid panels that do 500 to 600 or plus markers. What I think is really important for CLL patients to have testing done, obviously that one test called the flow cytometry is the test that gives you the diagnosis. Okay, those are the markers on your lymphocytes that tell you if you have one condition versus another. That's how the docs figure out, do you have CLL versus a different lymphoma versus a different leukemia. Okay, those are the markers for flow. FISH, the chromosomal abnormalities, so fluorescent in situ hybridization, or FISH, looks at chromosomal abnormalities that are on your CLL cells specifically. So those should be done as well. That tells people, like, where are they with some prognostication? Do they have more favorable disease? So it's a person with 13q deletion, for example, do maybe somebody have more aggressive features, maybe a 17p or a p53 deletion. So those are chromosomal abnormalities. And then you have the molecular testing. So that's the immunoglobulin heavy chain gene rearrangement, or IGHV. You might hear mutation, unmutation. That's another prognostic marker to help people. These large lymphoid panels, and that might be what you're referring to, there are markers that look at molecular mutations that can be associated with your disease as well as other lymphomas. And they're just these huge panels that just get sent off. And what's really more relevant for CLL patients has to do with the TP53 mutation. So usually we say at the minimum, somebody should have that done, and the FISH and their IGHV status. There are molecular mutations, though, that are associated with CLL that we're learning about. They just don't impact treatment yet, like the Notch mutation or SF3B1. There's some other molecular mutations that you can get off these huge panels, but they haven't, we're more using them for academic purposes. As we learn about people as they go through to see how treatments influence or will they be players in certain individuals. But right now, those aren't the features that will change how somebody is treated. And for some individuals, they may not all be covered. Just so some of these large panels may not be covered because they're not part of standard testing for CLL. So just so you know, but major academic universities do that.
Okay, so that sort of answers one of the other questions we have. Does knowing this information affect treatment choice? You just indicated that it does. And do these markers change over time?
So these, when we talk about the chromosomal abnormalities, right? So they can change over time. So your molecular status typically doesn't change. You're either mutated or you're unmutated. But your chromosomal abnormalities can change. Now, typically, they're not necessarily going to change on somebody who's never been treated. So let's say you got it when you were diagnosed, you were tested, and then 5 years later, you need some treatment and your doctor repeats that panel. It probably isn't any different because you've never been treated. So it should likely be the same panel. But once somebody's been exposed to therapies, there's no doubt that the disease can become more resistant and you can acquire different chromosomal abnormalities, different mutations that can change. And just, it really kind of tells us a little bit more about your disease and where you stand at the present time because you've been exposed to therapies. And so there's no doubt that people can acquire additional abnormalities or change their features over time because of exposure. And it really just talks about resistance.
Okay. When should a patient test for MRD or minimal residual disease status?
So these have to do with, we're getting into therapy now. So these have to do with what we're talking about when we talk about time-limited approaches. And these have to deal more so when we talk about the usage of venetoclax for patients. So venetoclax is a BCL2 inhibitor. Many of you might be familiar with this. It's a pill. It's often combined with one of our intravenous medications, one of the monoclonal antibodies, either rituximab or obinutuzumab. Those are intravenous. And those are time-limited approaches that are given either for a year or 2 years. And so when we talk about minimal residual disease, it's in the context of those time-limited approaches, unlike the BTK inhibitors that many of you also might be aware of, like ibrutinib or acalabrutinib or zanubrutinib. We can talk about pirtobrutinib. But the point is those are continued right now. If somebody's on them by themselves, we tend to continue them as a chronic daily medicine. So MRD really is talking about the time limited and the testing. So for many individuals, some of us will test after, let's say you approach that 12-month mark or the 24-month mark. We're trying to get an assessment of where your disease is. Now, in the community, and this is, so I caution this because again, this is something that MRD is evolving. In other words, that folks like myself and other CLL experts are trying to figure out how we can use MRD to best tailor treatments to specific individuals. Now, on the whole, we know that these time-limited approaches have been really, really effective for patients, which is great. The majority of patients respond, and many become MRD negative, meaning no evidence of CLL after therapy. However, we understand that there are patients who might still be MRD positive. The question is, how do we use that information? And that's what we're learning. So for most, we are telling people that if they've had a year of therapy or 2 years of therapy on one of these time-limited approaches, the likelihood is your oncologist might just stop treatment, even if you are MRD positive, because we don't yet know what to do with the MRD yet. And that's true. Many of us in academic medicine may be tailoring in that. We have certain protocols that we're looking at to fine tune this, because there are some individuals who it may be beneficial to continue them longer on therapy. Or for some of those, it may not. In other words, that their MRD doesn't change. Me giving you more therapy may not actually get you any more negative. It may not improve that response. And so why should we keep you on more therapy? So those are kind of things. We have some large studies that are running right now that are going to try to help us tailor that therapy a little bit better so we can see where we go forward. because then it may even be much more tailored than it is now based on some of your disease factors. Oh, if I have this chromosome, it's good to stop. And no, that one needs longer time. So there are many factors that go involved, and MRD and testing is evolving. I don't mind having someone being tested, of course. I think it's a good thing just so we know and so we could say where somebody is. But what you do about it is another question altogether.
Yeah, we're always reaching for it, doctor. We're always reaching for it. Okay, we'll move on to some other questions. Is tiredness one of the symptoms of CLL? And if so, is it because of the elevated white blood cells?
So this is a great question, and one that's really difficult to answer. Like they're not all. But the point is that, sometimes patients can be fatigued and it has nothing to do with how high or low their white count is. And can it be their disease? Sure, absolutely. Can there be other things too? Yes. So, I think what's important to know is, do I have patients with CLL who are fatigued? Absolutely. That I think is due to the disease? Absolutely. But at the same time, you do need to tell your physician and team again, because sometimes there could be another reason too. And that may be important for the doctor to know. I almost think of it like a diagnosis of exclusion. Like I'm happy to blame CLL on everything. But the point is what if there may be other things that my mind starts thinking about when somebody's telling me they're fatigued besides their CLL that I want to rule out. And so I think, yes, it can absolutely be due to your disease, but make sure your team knows, because there might be something else that needs to be checked or evaluated. And there's no doubt that as patients, and maybe this is answer your question also differently, as patients are progressing, so they're getting closer to needing treatment. So if somebody's white count, you had mentioned in the question, is it due with your white count? In the sense of if somebody's rapidly progressing and getting closer to needing therapy, yes. Do I think that the likelihood is that fatigue might be tied into it if somebody's really progressing? Yes. Is it just due to your white count being high? No. So it has to do with the tempo of somebody's disease. And that can play a role for sure, but it's not necessarily, oh, my white count's 20, do I not have fatigue compared to somebody who's got 100? No, I think it's depending upon where those diseases are in those individuals, and is there anything going on that I need to know about just to make sure it's not CLL or CLL.
Okay, and sort of a follow-up to that is there anything I can do nutritionally to create more energy, or should I just rest?
Yeah, fair enough. So very complicated question as well. There's no doubt that I think there's a lot we don't know about diet and nutrition and illness. And there's lots of, I know, because you all do this, there's lots of things you can get on the website and Google and be like cancer and diets, and you'll come up with thousands of responses and supplements and this and that and the other thing. And unfortunately, we just don't have a lot of primary data in CLL. And what affects one cancer may not necessarily be the same for another cancer, and vice versa. It's always important that if you're taking good care of, there's some things that are common sense. We know that people who exercise, that stimulates endorphins, that's very good for lots of diseases, including cancer and CLL. So I would say to stay active if you can. Of course, you should listen to your body. So if you're fatigued and need to rest, of course you should rest. But the point is not to sit on your duff just because of the reason of your CLL. So you need to work with your body and listen to it depending upon where you are, but you should try to exercise, because incorporating exercise actually helps with the fatigue issues, with actually decreasing infection issues because of the endorphins and the cytokines, and keeps you healthier. And there's very good data about that in infections as well. When it comes to diet, we have a lot more trouble. So I always tell my patients a well-balanced diet for sure. Things that help your cardiovascular system probably help your disease as well. So not eating tons of, sugars and fried fatty foods and carbos and things like that, but well-balanced. There are things that we just don't know. Many of you probably know about the study with green tea and CLL. And obviously it's a study that we haven't been able to do further evaluation for. And the formulation of the green tea on that study is not something that you all can get access to. So I always tell my patients, I don't mind you taking some, there's this great antioxidant. I don't mind you taking some, but you also have to realize that any supplements or drugs that we prescribe for you have to go through your organ systems. So your kidneys and your liver, or both. So if you're going to take over the counter stuff or not even over the counter, herbal stuff, things that you get on access to, please let your team know as well. There could be drug interactions with other medicines you might be taking. So you want your team to look into that, and you want to make sure that your organ systems are safe. So I give a lot more flexibility to my patients who are not on therapies versus when they're on, because again, the drug interactions. So just talk to your team, but a well-balanced diet, exercise, and rest are all important, I think, for your immune system.
That's always a good prescription, right?
I think so,
Yes.
for sure.
Okay. Are you familiar with non-treated or treatment-naive CLL patients having increased occurrence of bowel issues, and would treating the CLL help resolve those issues?
So this is a great question. These questions are good because they make me think of so many different things, which of course may not be the same thing that the person's asking. But CLL, there's a lot of overlap with autoimmune things too. So so first, in general, not typically. So just so you know. But there are different ways that I could think about CLL and the bowel. So one is directly. So there are patients who can act direct bowel involvement. That is not so typical for CLL. That's more typical for some of the lymphomas, like mantle cell and Malt's lymphoma. They can have direct bowel involvement where they need to be treated for that. It can happen in CLL, but not so common.
Maybe SLL, doctor, with lymph nodes?
Yeah, you would exactly in that sense, right? So yes, so you would think about bowel involvement of little tissue, exactly. But it's again not such a common phenomenon. Even when I think about all the lymphomas, it's really relegated to a few different types. It's not common, but it can happen. I'm not saying it can't. So that's one, and that's when you have the endoscopy and the colonoscopy to look. And then the second is sometimes in an autoimmune fashion. So people can have other autoimmune issues. So I like to think of CLL as a disorder of your immune system. And there are some of you, unfortunately, that may have more than one different type of immune disorder. So you can have overlap syndromes of, I have CLL, and I also have rheumatoid arthritis, and I also have Hashimoto's thyroiditis, and I have celiac disease in the bowel. So people can have other autoimmune issues, and sometimes treatment of those. For some patients with celiac, I'll be like, let's try the diet, let's do gluten-free, let's go through the mechanisms, have appropriate testing with a gastroenterologist, of course. And then if that's not working, then the question is it somehow immune related from the CLL in that sense? And can you do some sort of therapy? And again, this would be in conjunction with your team. Because again, it would be a little out of the box. Have I done it? Yes, but it's not common, just so you know. And then we think of more antibody mediated treatments, particularly if their disease is otherwise behaving okay and they don't need full-blown therapy for their CLL. So sometimes you can use things like rituximab. But this is again a conversation. So can it happen? Yes. Is it less frequent? For sure. So you need a proper evaluation. The gastroenterologist should work with your oncologist to see if it's related or if you have another immune disorder that might be on top of that.
Okay. All right. And this probably plays right into the same area. Does CLL cause osteoporosis?
Okay. Now that one, I'll definitely say probably not.
No?
Not that I'm aware of. Not to, again, I blame CLL on everything, but not directly speaking. So remember, there are things that happen as we age too. And so, and for women, it becomes trickier because of our hormones change and we're older. It's an older patient population in general. So typically no. So your bone health and your bone density are separate from CLL. Now, there are ways differently where CLL can affect the bone marrow, as you know, because it's a bone marrow disorder, but it shouldn't affect the actual stability unless in very rare, and this is rare, in rare circumstances, sometimes it can cause more of a lytic lesion in the bone. This is not osteoporosis though. This is still direct disease involvement that needs treatment because it's causing almost like a lytic or a compromise to the bone. But in terms of osteoporosis and CLL, no, totally different.
Okay. And also an add-on to that question would be, would osteoporosis medications be helpful in any way for someone with CLL, or would they impact you negatively or positively in any way?
Yeah, as far as we know, and I apologize because obviously there's not a lot of data on this at all. As far like, in other words, if I have my patients who have osteoporosis and need to be on a medicine for their bone health, for bone density, absolutely. There's not a problem. There's usually no interaction. And I mean, obviously what you want to, we know that the bisphosphonates can have some side effects. So you want to talk about the side effects with your doc, but it doesn't have an impact on the treatment for your CLL or on the disease itself. So it's totally fine to receive. And in fact, right, we were trying to prevent further bone loss so you don't have fractures and things like that as you get older. So it's totally fine, separate entity in my way. Do I think that CLL may have, so if somebody breaks a bone or has poor dental hygiene or other infections or surgery, can it impact maybe healing? Possibly, right? So we think about CLL and the immune system. There's no doubt that there might be a relationship somehow to healing in that sense when we talk about the bones and other types of infections. But osteoporosis and CLL, no. So it's okay to get your bone health taken care of.
Okay. All right. We'll move on to some questions that are about therapy, specific therapy. Is obinutuzumab without venetoclax used as a treatment, or have you prescribed venetoclax alone?
Okay. So let's first talk
on that.
Yeah, fair. So let's first talk about the antibodies in general. So rituximab and obinutuzumab, as I mentioned previously, are two intravenous medicines, and now Rituxan can actually also give subcutaneously as well. Two medications that are targeted for CD20, one of the markers that are expressed on your CLL cells. And you oftentimes, traditionally, those have been combined with other therapies. And so it is very common that you'll see these in conjunctions. If you think about the chemoimmunotherapy we used to give, fludarabine and cyclophosphamide with rituximab, or chlorambucil with obinutuzumab. So these antibodies were oftentimes combined and very synergistic and potent with other therapies. So similarly, they've been combined with some of our new oral targeted therapies, both with the BTK inhibitors, as well as venetoclax. And so typically, they're usually in conjunction. When we talk about them as a single therapy by themselves, so obinutuzumab by itself, for example, usually, we do not, many of us would not feel that somebody should just get an antibody alone, if without sort of augmenting that maybe with another therapy, just because it may not last as long. The response duration is not as durable as when it's added to another therapy. The exceptions of using antibodies, they're very helpful for these autoimmune issues that I spoke about before. They're very helpful for autoimmune hemolytic anemia, autoimmune thrombocytopenia, and oftentimes maybe given with steroids. And so there we might use it with alone because of that reason. And that's where you'll often see them given as a single agent. Back in the day, we often used to also give them to people who we didn't have these targeted therapies for. So back in the day, before we got the BTK inhibitors and venetoclax, some of us would just give an antibody because we thought that was better treatment than chlorambucil. And so some people might have just gotten an antibody by itself in that day to kind of clean things up, shrink the lymph nodes, improve the blood counts, but knowing that it may not last as long, but we thought that was more gentle than giving, let's say, fludarabine, cyclophosphamide, rituximab if somebody was much older or frailer. Now with the targeted therapies, we're often, we have the targeted therapies, and many of us won't be giving single agent antibodies by itself, with the exception of the autoimmune stuff. Now, can you give venetoclax by itself? Well, interestingly, venetoclax was approved initially as a single agent for patients with a 17p deletion as continuous therapy, kind of like ibrutinib and acalabrutinib and so on, as a daily therapy. Then fast forward to obviously more when we started combining the medicine with the antibodies like obinutuzumab and rituximab, this became that time-limited approach that I was referring to earlier. And so you now can truncate the therapy and stop the venetoclax. Are there some patients who might benefit from staying on therapy? There might be. There are. And so I think, again, that's a conversation you need to have with your physician, because most people will use venetoclax in a time-limited fashion, unless there are some extenuating circumstances that maybe they feel that the person needs to stay on it.
Okay. What is the advantage of the non-covalent BTK inhibitor over current BTK inhibitors like ibrutinib and acalabrutinib? And should it be used frontline?
Okay, so these are, for those who don't know, these are what we're talking about, the non-covalent BTK inhibitors. This is pirtobrutinib, and there's I can never say this one, nemtabrutinib. all these Brutinibs. These are the newer kids on the block. Their mechanism is a little bit different. And so they there are studies that have shown, so patients can develop resistant mutations to the covalent BTK inhibitors. So eventually your disease may lose its response to those current drugs. And those are ibrutinib, acalabrutinib, zanubrutinib, for example. And so there were studies first with this, the one that's furthest along in development is the one called pirtobrutinib in patients who have developed resistant mutations. That they went on this study with pirtobrutinib, which is it's a little bit different because it's non-covalent. And so it can overcome some of the resistant mutations that people got on the covalent BTK inhibitors. And so there's data showing that patients were able to respond and have a nice response duration, although this data is still young, but maturing. And so this has certainly been a possibility of going to this agent after somebody has progressed on one of the covalent BTK inhibitors. And so is there no doubt that I think that these drugs will be approved soon? I do. And do I think that there'll be players? I do. The side effect profile so far have been very good. Not to say, you know, remember we talk about all the side effects with BTK inhibitors. They seem to be very much reduced as well. Not to say they're not present, but they're much reduced. And so do I think that, you know, we have to figure out what's the right sequence of these agents? Do we go from covalent to ven to non-covalent? Or can you go from covalent to non-covalent and then to ven? Can you have them up front as the question that came in? There are clinical trials running now looking at upfront, and there are combinations. So there are studies also combining pirtobrutinib with venetoclax or an antibody or both, so a triplet, and looking at how to best fit these newer agents. But I think the good news is for all of you is that this gives us another drug in our armamentarium to play with. So that if you progress on one agent, you have another agent. And so that's the goal. I mean, our goal is obviously to cure the disease, but hopefully if we have we can, you know, obviously use these newer therapies to our advantage. It gives you all ample opportunity to have other therapies as well.
Okay, and sort of leading along with that, are there any serious delayed side effects for those on the long-term treatment with BTK inhibitors? Since some of these patients have been in clinical trials for almost 10 years, are you seeing anything in long-term use?
You know, it's so in my experience, and I have some patients, as you said, who have been on the initial ibrutinib being the first to market on ibrutinib for almost 10 years. In general, my experience has been that for the folks who come off, they're coming off on the earlier side within the first couple of years if they're coming off. Those who are been on BTK inhibitors in general, again, this is a generality, those who are on BTK inhibitors 4, 5, 6 years are usually, no, those guys are good. You know, in other words, those are patients that rarely have side effects and are doing fine. So it's rare to have late-term side effects if you're doing so well on a BTK inhibitor for that long. And those are the guys that you see, and that's why that curve looks so good from the initial ibrutinib studies. Those who are in long-term follow-up who have been on drug for 7, 8, 9 years are good because they've done so well and they don't come off drug. The ones that are coming off that first year and a half or 2 with side effects and issues. And so they're declaring themselves and coming off therapy. But generally speaking, I'm not seeing any newer or different. And as I said, less side effects actually later on.
Okay. Do you expect CAR T to be FDA approved? And what is the longest remission that you know of with CAR T therapy?
Well, so that was actually recently reported. Was it this past summer? I can't remember, in the New England Journal, in the New York Times. The first CAR T, it was like 10 years. One of the first initial studies of CAR T and CLL. So CAR T and CLL actually, CAR T was actually evaluated first in CLL and in ALL before it got approved for relapse refractory non-Hodgkin's lymphoma patients. Obviously, the side effects profile is what prohibited it initially from getting approved in CLL. In ALL, it got approved because there were much less therapy options, and it was a bridge for certain. Remember, acute leukemia, very different disease that needs to be cured right away, or patients die. So acute leukes are very, very different beasts. And so it was a bridge to transplant for a lot of patients. And so that got approved in ALL first. And then it got approved for multiply relapse aggressive lymphoma patients with less options. And so the side effect profile of CAR T has certainly gotten better and come a long way. There's no doubt about it. And it's very, they're very good responses to many individuals with this therapy. What's unfortunate in CLL is that, because of all these great therapies that have come about over the past 5 to 10 years with the BTK inhibitors and venetoclax and the antibodies and things like that, it almost relegated, the CLL patients, CAR T just kept moving down the pike because there are all these active therapies with less side effects. And so where CAR T is going to fit in CLL, there obviously is a need. How to put that, where we're going to put that is still, evolving, right? So typically we would, theoretically, in many individuals, we would say we would be giving them to our multiply relapsed CLL patients who have failed the BTK, failed venetoclax, so on and so forth. But to be fair, the response duration for some of these individuals, that was one of those studies when it got reported in the New York Times, where some of those individuals were, still free of disease 10 years out. And it's interesting, I used to say that could still happen even to patients who were on chemoimmunotherapy with FCR, right? So depending upon the kinetics of somebody's disease, if your disease biology is really one indolent, you may not need a lot of therapy and stay in remission a very long time with whatever therapy you get. And then there are those individuals that obviously go through multiple different types of treatment options throughout their journey and need a more aggressive treatment. So CAR T, do I think it'll get approved in CLL? I do, for sure. I think what we need to figure out is, how to best, and I think it's still going to be a very much more tailored individual type of therapy that you and your physician are going to discuss in the options of all the therapies that currently exist until we can figure out exactly where best to place it in the armamentarium for CLL.
Okay. And the sequencing of treatments still being discovered.
Absolutely. Absolutely. Well, the good news is obviously there's much more treatments. And so that's a good thing.
Sure. Do you feel that a cure for CLL will be found in the next 5 years, 10 years?
During my lifetime, I hope. I would love that. Yeah. I think what's been tricky about CLL is that as many of you have probably gathered from being online and listening to a lot of these forums and talking about your own individual journeys, the biology of this disease is not very homogeneous. And so unlike some other cancers where we could say, oh, there's this one mutation and we fix this, and it's been trickier because the biology is so different. And so it's almost like many diseases in one spectrum. And as I said, there are some individuals that never need treatment for their disease. And if I could do a blood test, my patients know I say this, if I could do a blood test on you and I knew you never needed treatment, you could walk out the door tomorrow and be done with me, that would be great. And then there are those individuals who can go 10 years and then need treatment. And then of course, those who are under 5 years and getting treatment sooner. So the biology changes and is very different in each individual. And I think that's what's been tricky for us, for those who deal with this disease and try to find new therapies, is that it's not straightforward. And so I think that there are many escape mechanisms there. We talk about the B cell, but there's obviously many cells that impact how these malignant B cells stay alive in your body. In some individuals, they play more of a relevance than in other individuals. And so those escape mechanisms, it's trickier. And so there hasn't been a one size fits all that we've been able to give somebody something and say, okay, great, we're done. And so I think it's just been trickier to find a cure. The therapies are getting better and we're honing in on certain mechanisms and things that I think for sure, obviously, because the survival keeps getting better. So that's good, right? So we keep pushing the envelope and we keep doing a better job. So I do think that the real hope is in sight. But don't ask me to say if it's 5 or 10 years.
Yeah. Okay, doctor, we're going to move on to some of the live questions that have come in. So they're going to be all over the place a little bit in terms of topic, but we'll give it a shot. A growing number of patients are taking venetoclax, which is a timed therapy. Which tests and factors do you use to determine if a patient can take a therapy holiday?
And that's what we talked about, the MRD testing. I think that's probably what this question goes for. Although remember I said that some patients may be in a complete remission, but maybe they have a little bit of evidence of CLL by the flow cytometry. That's the test that the doctor will send to see if you still have residual disease. If you had big nodes, maybe they'll do a CAT scan to see if they're clean. There are some people who need a holiday for other reasons. They may have, maybe it's brought their blood counts down and they have a lot of what they call cytopenias. Either they're neutropenic all the time, or maybe their platelets are low. And so sometimes the doc will reduce the dose or stop the therapy for that reason too. But I think I think you were referring to is MRD testing. And so, yes, I think if you are otherwise, unless there's a reason that your doctor thinks that you need the therapy longer, they might give you a holiday depending upon if you got it for 12 months or for 24 months, 12 months in the frontline setting, 24 months in the relapse setting. They might give you a holiday otherwise, unless there are other features about your disease where they may want you to continue. So talk to your doctor.
Okay. Are CLL specialists at major cancer centers generally in agreement about when to start treatment, or is it worth getting opinions from more than one specialist at that level?
At the level of academic, I gotta say that pretty much we probably will all agree about when to start treatment in our eyes. There's been less variability about that. We might talk about differences of treatment options, but most people will tend to agree within a couple of months. And remember, if somebody's really progressing, if their nodes are really growing or they're developing cytopenias, we're not talking about the person not needing treatment. We're just arguing over when. And usually that's within a very small, tight range of when, which is very different than others where there may be people getting nervous of a high white count, but otherwise person's totally fine. You won't get that issue, that concordance, that there won't be much of a difference between the CLL experts on that stuff. Okay. Whereas that may be more of a difference with CLL, non-CLL experts, yes.
Yes. Okay, someone asks here, I'm on watch and wait for 4.5 years. How can I find out more about off-label low-dose naltrexone? My PCP and oncology naturopath have both suggested it, but my CLL oncologist doesn't know anything about it.
No, I think that's fair. Remember, we were talking a lot about, there's a lot of things that we, that could be beneficial to CLL patients, but there's not a lot of data, a lot of clinical data, which becomes difficult, right? So that you can then have a conversation with knowing that there may not be as much data behind it in a true, as I said, the closest thing we've done so far was that trial in green tea by the Mayo. And so, there's not a lot of trial data, and that's what we're really looking for. It's not because we don't want it. It's really because of a lack of funding. And, it's very hard on a rare disease compared to other diseases like breast cancer and prostate, where there's a lot more individuals. The funding isn't as robust in some of the rare diseases like the hematologic cancers. And so I think that it's a balance that you have to then have a conversation of, is this okay and safe to do? Who's willing to watch me if I want to do something? Again, remember about organ function, very important. And, sort of making a compromise, and your CLL expert or doc may say, look, there's no data in this. I'm not really, in favor of this, but, if you're going to do it, you have to understand the risk benefit ratio of what you're doing. And that's the conversation you have to have.
Okay. All right. Another viewer says, my only annoying symptom, I assume this person's in watch and wait, is a recurring cyst in various places, which I attribute to a low immune system, but my numbers are not low enough for infusions. Will starting treatment with a BTK inhibitor improve or worsen my situation with the infections?
So when they meant cyst, and I'm sorry, since some of this is, some of this is important because it's always the devil in the details, so to speak. Are you talking like an abscess, like those kind of like real infection cysts?
It just says,
or are you talking
recurring
like,
cysts in various places?
Those like lipomas. So, okay, I'm just going to try to speak to this. So If there's real infections going on, the question is, there's no doubt that there's some patients, if they get recurrent infections, even if their numbers don't look like they need treatment, with recurring infections, sometimes I do think that somebody is progressing and they might need some treatment. That being said, that's not so, usually I like to see that somebody's got some progressive disease. If they're having something that's recurring infections that need to be, are there other things that can help that person? Do they have low immunoglobulin levels? Can I give them IVIG that might help decrease their infections and need for antibiotics because of these cysts that are abscesses or cellulitis all the time? Again, I'm not sure what these cysts are, but if they're benign cysts, probably not. But if there's something that's requiring antibiotics, and that's what I'm taking it to mean, infection, then the question is, why do you keep getting them? So yes, then would a trial of IVIG might be warranted. Sometimes therapy initially, you'll still have infections and things. And remember, even on these therapies, there's about a 20% risk of infection. So it's not that the therapies don't have infection risk associated with them too. So you have to keep that in mind. But is there a way that maybe the team can better help that person through the infection, and then maybe you really don't need treatment? So I think somebody needs a little bit more detail about that.
Okay. If a patient has achieved UMRD, undetectable minimal residual disease, with obinutuzumab and venetoclax, and they relapse, could one or both of these treatments be used again?
So that's a great question. So there are some trials that have been running that suggest that possibly yes. And there's really actually came from an older trial with venetoclax and rituximab in the relapse setting called the Murano study, where patients, when they relapse, were re-challenged. So what we're trying, and there's some newer studies that are actually looking also in the front line with venetoclax and obinutuzumab, looking at that exact question. So when you relapse, many of us feel that if somebody relapses very quickly, so let's say you're relapsing within the first 6 months to a year, maybe that may not be the right therapy to go back to, since you're relapsing so quickly after this really good therapy, because we expect that to last a while. But there's actually a trial addressing that question called the Revenge study. But if let's say it's been a couple of years, though, let's say you've gone 3-4 years, you probably could get re-challenged. Absolutely. And that you could maybe still use that, or could you use the BTK and then eventually go back to Vent? So there's different ways that this can be done for sure. But yes, the likelihood is many individuals probably can be re-challenged with either Ven or the combination.
Okay, great. A viewer asked, do you think zanubrutinib will become the new standard for relapsed patients?
Well, so it could be, I think it could be standard for relapsed or frontline, right? So I think many of us feel comfortable with all the covalent BTK inhibitors, and there's definitely trials with all of them, right? First, we need the approval. So hopefully, not that it's prevented anybody from using zanubrutinib, because zanubrutinib is already approved in Mantle, Marginal, and Waldenstrom's, but it's awaiting their final approval in CLL. But the studies have been done in both relapse and in the frontline setting. So I think people just extrapolate, that data, and will decide to use whichever covalent BTK inhibitor that they think is better for their patients. So I think Xanu could be used in frontline or relapse.
Okay. Is there any research from ASH on CLL that you're excited about?
Oh, now that's hitting below the belt. That's like priority. That ASH is this week. So we're all excited. There's lots of data coming out, a lot of updated data. So you'll see lots of combinations with the orals, so BTK plus venetoclax. You'll see lots of combination of BTK, venetoclax, and antibodies. Remember, with all these combination strategies that are time limited, we know the responses will be really great. We're looking for durability, and we're looking to see if combining drugs will not only give you a time limited approach, but also be better for certain different disease types, meaning will combining things be better for patients with more aggressive features? Will that work better for those individuals? Or is a sequential approach? Remember, you can go from one agent to another agent. So we still have that strategy. Do we know if one strategy is better than another? Not yet. Hopefully some of the clinical trials that we have going, which need longer follow-up, will help address that issue. And then there are newer molecules. We're always looking for newer therapies. As we said, we're trying to cure the disease. So there are newer, so look at bispecific monoclonal antibodies. There'll be some early data about that. There'll be more data about CAR T. There are also protein degraders, so new molecule that way. So we're always looking for newer drugs. And there's some head-to-head data that's going to be presented as well. So stay tuned. I'm sure CLL Society will have some ASH updates after.
Okay, doctor. I'm told we're running out of time here, so we're going to say thank you. This has been it's been fun for me and really informative for our audience, and I hope that you can come back and join us again sometime. Thank you so much for your expertise. But before we end the program, are there any closing thoughts? Is there anything you'd like to say as a final thought?
I know, I'm so sorry. I know there's a ton of questions, I'm sure, and try to group them, with COVID and therapies, and there's a lot going on. I think the final thought is COVID's not going away. You guys need to be cautious and optimistic, and take care of yourself and do wear your mask, and get your vaccines. But you do need to balance, because there's some people that really haven't been out in 2 years, and you need to get out a little bit and try to balance it as best you can so you can enjoy some time with family and friends, again, mediate. And in terms of therapies, there's lots of good stuff going on with CLL. There's lots of hope, lots of newer therapies, lots of strategizing some of the existing therapies. And I think you really all have some real good optimism for the future, to look forward to some of these treatments and us sort of figuring out how best to use them, and continuing to improve the outcome of folks with CLL. So I'm hopeful, and I hope you are too.
Thank you. Thank you so much for your time and your expertise. We're really grateful for your participation, and thank you for being such a champion for our community.
Happy to help.
Okay, and thank you to everyone who joined us today as well. And there's a few brief reminders. Please complete the short survey, the event survey that's linked to the comment section on Facebook, and it will also be shared with everyone who registered for the seminar. This is our second Ask Me Anything Facebook Live event, and we really want to hear your feedback and see if you like this format. Please join us on January 12th for CLL Society's next webinar, which will focus on COVID-19 and any new information. If your question was not answered today, please send it to our Ask the Expert email service. The webpage for this free service will be provided in the comments section on the Facebook page, and can also be found on the CLL Society website under Programs and Support. This is the season of giving, so please remember, CLL Society is invested in your long life, and you can invest in the long life of the CLL Society by supporting our work. Thank you so much. This has been incredibly helpful and informative. Thank you.